Hello, everyone. Thank you for joining today, this webinar on lung protective ventilation of the neonate. Today with us, we have Dr. Gianluca Lista. He's the director and the head of neonatology, pathology, and neonatal intensive care unit at the Vittorio Buzzi Children's Hospital in Milan, in Italy. Dr. Lista, welcome. Thank you for joining us today, and the floor is all yours.
Good afternoon. Can you hear me?
Yes.
Perfect. Good afternoon to everybody. Thank you very much for inviting me. My talk today is about lung protective ventilation in the neonate, current states, and future needs. This is my conflict of interest statement. This is the outline of my presentation, a brief overview on conventional mechanical ventilation and high-frequency oscillatory ventilation. Then we try to give you some information about how to optimize mechanical ventilation to try to be really lung protective. And finally, some quick reference to the most common scenarios in neonatal respiratory failure and mechanical ventilation strategies. We know that we always try to use a non-invasive ventilation to manage the respiratory failure of the newborn, but sometimes the invasive ventilation is necessary. And we have to remember that the neonatal patient has a unique physiological characteristics, such as small airway, few collateral airway, very compliant chest wall, and low compliance of the lung. And we have to remember that the pathologies affect the newborn lungs are very different from the pathologies that affect the lungs in the next years, in the children or the adults. So we are trying to select some strategies in order to try to optimize mechanical ventilation to try to prevent ventilator-induced lung injury. These are the common conditions in which the mechanical ventilation is needed in the delivery room. And these are the common conditions in which the mechanical ventilation is needed in the neonatal intensive care unit. The indication for mechanical ventilation are the severe respiratory acidosis, or the presence of recurrent apnea, or severe clinical signs of increased work of breathing. For example, a Down score more than 7 or a CRIP score more than 7. The goal of our mechanical ventilation are to try to guarantee an optimal gas exchange, to minimize the risk of lung injury, to reduce the work of breathing of our patients, and always to try to optimize the patient comfort. In order to guarantee a normal gas exchange, to try to reduce the work of breathing, it's necessary to try to maintain the integrity and functionality of the barrier between the alveoli and the capillary. So we can try to guarantee a normal and adequate lung volume, but we have to take attention to reduce the risk or to guarantee excessive both minimum pressure lung volume, because we can generate a lung overinflation. And when we generate a lung overinflation, you can reduce the gas exchange because you increase the vascular resistance. Because when you increase too much the lung volume, you increase the distance between the lumen of the alveoli and the lumen of the capillary. During the last year, we had a progressive evolution in the neonatal ventilator. But how is the working principle of a neonatal ventilator? The neonatal ventilator is characterized by a continuous flow, is pressure limited, then it is time cycled. The problem is that when you have no synchronization between the patient and the ventilation, there is a continuous variability of the tidal volume. And with the variability of the tidal volume, you have a negative effect on the hemodynamics and on the lung mechanics. In this cartoon, I summarize the disadvantages of the non-synchronized mechanical ventilation, continuous changing of the tidal volume with the risk of volutrauma, barotrauma, to electrotrauma. A very important fluctuation of the tidal volume is responsible for a worsening of the gas exchange, in particular for the hypocarbia or hypercarbia that are responsible of severe risk of brain injury, like the IVH or periventricular echomalation. So it's very important to try to synchronize the patients with the ventilator. In the past, many modality of synchronization were used in mechanical ventilation, but only the use of flow sensors seems to be the much more important modality to synchronize the patient with the ventilator, using, for example, a wire anemometer that is placed between the endotracheal tube and the ventilator circuit. Using this modality of synchronization, we have some important modality of mechanical ventilation. The first one is the SIPBV, or assisted control, in which the neonatologist set a backup ventilation rate and where every spontaneous breath is supported by the ventilator. This modality of mechanical ventilation is typical in the acute phase of RDS. On the contrary, the SIMV, the synchronized intermittent mandatory ventilation, the neonatologist set a backup ventilation rate, but between the synchronized breath, the patient is left to breathe spontaneously. This modality of mechanical ventilation is often used during the weaning phase of RDS. In this panel, you can see the difference between the SIMV and assisted control in terms of tidal volume and mean airway pressure. During the assisted control, the tidal volume is generally higher than the tidal volume in SIMV, and also the mean airway pressure is higher than in SIMV because each breath is synchronized and assisted by the mechanical ventilation. In terms of effect of work of breathing, the SIMV seems to have a negative impact on work of breathing, but the assisted control, it's able to reduce much better the work of breathing, as is explained in this paper published in 2001, in which you can observe that the assisted control significantly reduced the work of breathing in comparison with the SIMV. In particular, during the SIMV, the spontaneous breath may generate a not adequate tidal volume, and there is a risk of increased work of breathing, especially during the weaning phase. SIMV assisted control are pressure targeted and time cycled modality of mechanical ventilation. On the contrary, the pressure support ventilation is a pressure targeted and a flow cycled method of ventilation. During the pressure support ventilation, the expiration starts when expiratory flow goes down to the 15 to 20% of total flow. With this modality of mechanical ventilation, the patient controls both the starting of expiration and the starting of exhalation. With the pressure support ventilation, there is a positive impact on breathing pattern. There is a good improvement of gas exchange and a good reduction of the work of breathing. Pressure support ventilation can be used in stable newborns and is not indicated in critically newborns with abnormal central respiratory drive. The SIMV plus pressure support is an halfway house between a complete ventilator assistance and rapid weaning. In this modality of mechanical ventilation, the patient is breathing spontaneously, but the ventilator supports the spontaneous breathing with a preset pressure level above PEEP. How to calculate the pressure support at the beginning? You can use this formula: peak inflation pressure less the positive end expiratory pressure divided for 2. This is the initial level pressure support that you can set for the baby. Using the SIMV plus pressure support, you can reduce the work of breathing much more than SIMV alone. In this cartoon, you can see which are the differences in terms of the effort of the mechanical ventilator and the spontaneous breath of the patients. During IMV, the spontaneous breath can coincide or not with the mechanical ventilation. During the SIMV, between the synchronized ventilation, the baby is left to have a spontaneous breath. During the assisted control, each spontaneous breath is supported by the mechanical ventilation. And during pressure support ventilation, The spontaneous breath is supported only with a pressure support over PEEP. During the high frequency oscillatory ventilation, the mechanical ventilation give a very high frequency of ventilation, about 600 to 900 breaths per minute. There is an active aspiration and are generated only low tidal volume, just a little bit more than the anatomical dead space. And there is a marked damping of the pressure waveform from the airway opening to the alveoli. This is the reason why the high-frequency oscillatory ventilation in animal study seems to be a very important promising lung-protective ventilation. During the HFOV, the pressure oscillates around a continuous standing pressure and is very different from the conventional mechanical ventilation. The gas exchange in conventional mechanical ventilation, the oxygenation is regulated by the FiO2 emitting wave pressure, and the CO2 washout is regulated by the mute ventilation, that is the product of the respiratory rate and the tidal volume. Gas exchange in HFOV, oxygenation is regulated by the FiO2 and the continuous descending pressure, and the CO2 washout is regulated by Hertz and delta pressure. The DCO2 is very important in order to give information about the capacity of the ventilator to remove the CO2 and depends from the frequency per the square of the tidal volume. In order to guarantee a very important washout of CO2 during the HFOV, you can increase the amplitude, you can reduce the frequency. And the tidal volume is frequency dependence. If you reduce the frequency, you increase the tidal volume. BPD is a multifactorial disease and are involved both prenatal factors and postnatal factors. For the postnatal factors, mechanical ventilation is a very important predisposing factor to BPD. BPD still remain very frequent in all over the world, in Europe, North America, Asia, Oceania, especially for a very tiny baby, for a baby with a low gestational age, less than 25 weeks of gestational age. And we know that the length of mechanical ventilation is associated to the occurrence of BPD. Longer is the length of mechanical ventilation, the higher is the correlation with the BPD. Non-invasive ventilation approach is related to much more alveolar complexity, and mechanical ventilation, unfortunately, is related to alveoli simplification. Mechanical ventilation induced the ventilator-induced lung injury, but induced also the ventilator-induced brain injury, in particular the occurrence of the periventricular echomalacia and severe IVH. So we are trying to reduce the occurrence of the ventilator-induced lung injury that is declined by the biotrauma, atelectrotrauma, volutrauma, and barotrauma. So we are trying to maintain the lung volume in the middle zone of the pressure volume curve, but it's not easy for the neonatologist. So how we try to reduce the lung injury, so how we can try to reduce the risk of BPD, so how can we set a lung protective strategy? We have to remember that during mechanical ventilation, two issues are very important, stress and strain. Stress is the force per unit area for the lung, is the transpulmonary pressure. The strain is the parameter that describes the deformation, and for the lung is the ratio between the tidal volume and the end respiratory lung volume. When you apply the stress, the lung tissue can agree the strain with its progressive deformation until a breakpoint. If you overcome this breakpoint, we have a lung rupture. We can mimic the lung tissue like a fibrous network showing free fiber lines in parallel with multiple springs. This is the resting position of the lung. When a force is applied and the system is homogeneous, there is no problem because each line carries the same forces. If one element, like in the panel C, is consolidated, there is a big problem because this line is unable to carry the force, but not the strain. So the great risk that we can have a lung rupture. This is very frequently in a non-uniform lung aeration. This is what happens in many cases, both in the pediatric patients and the adult patients. We have to remember that all the ventilator parameters and lung compliance interfere on the tidal volume. This is the reason why the recent European consensus guidelines on the management of respiratory distress syndrome suggest in mechanically ventilated infants to use the targeted volume ventilation and to use the high frequency as an alternative strategy. I think it's important to remember this very interesting paper written by Lachman some years ago. The title was Open Up the Lung and Keep the Lung Open. There are very important issues to remember. The first one is to try to reach an opening pressure. The pressure is important to open up partially collapsed lung. Then we try to guarantee a normal gas exchange, a normal alveolar ventilation. It's very important the role of positive end respiratory pressure. And always we have to try to prevent a lung damage. We have to remember that the surfactant distribution is regulated by the amount of the lung that is aerated, because the surfactant distribution is much more in a more aerated lung. So there is a possibility role for a lung volume recruitment maneuver before to give surfactant. In the animal study, using the HFOV, we have 4 lung volume recruitment methods. The first one is stepwise increments of the pressure. The second one is use a systemic dynamic inflation. The third one is I use a repeated dynamic inflation. And the last one is a standard minimum wave pressure. In terms of thoracic gas volume, we know from these animal experiments that the use of escalating stepwise increments of pressure seems to be the much more important in order to guarantee the maximum thoracic gas volume and to reduce the portion of the lung that are non-aerated and to reduce the risk of over-distended lung. So when we want to use a very good open lung strategy, we have to remember to consider the lung hysteresis curve. According to that rule, we know that the lung volume at any given pressure during exhalation is higher than the lung volume at the same pressure during inhalation. Some years ago, our colleagues in Amsterdam using the lung volume hysteresis in order to optimize the lung volume strategies during high-frequency oscillatory ventilation. Baby in oscillatory ventilation for the RDS started with a CDP set between 6 to 8 centimeter water and the FiO2 necessary to maintain a normal saturation. Then step by step increasing of the CDP 1-2 centimeter water every 2-3 minutes, a stepwise reduction of the FiO2 in order to maintain the saturation. The clinician stopped to increase the pressure when the oxygenation no longer improves and when the FiO2 need was less than 0.25. So they start to reduce stepwise type the pressure 2 centimeters of water every 2-3 minutes until the oxygenation deteriorates. The oxygenation deteriorates because probably the pressure was below the closing pressure of the lung. So they recruit the lung, re-incremented again the continuous standing pressure, and so maintain the continuous standing pressure 2-3 centimeters above the closing pressure. In conventional mechanical ventilation, a big dilemma is to use a pressure-limited or voluntary ventilation. If you use a pressure-limited mechanical ventilation, in case of worsening of compliance, the ventilator is unable to maintain the tidal volume and the lung volume. During involuntary ventilation, in case of worsening of the compliance, the ventilator adjusts the parameters in order to maintain the same tidal volume. So if you use a volume targeted ventilation, you can reduce the risk of hypoventilation. The problem is that when you use the surfactant, because if you use the surfactant, you increase the compliance. So the pressure value that you use before surfactant therapy are able, for example, to generate a tidal volume that is enough for this baby 1 kilo. When you give surfactant, there is a improvement of compliance, so the same peak inflation pressure is able to generate a very high tidal volume. So when you use a conventional pressure limited ventilation, there is a high risk of overdistension and subsequent lung injury. So there is a high risk to give a barotrauma when you use a peak pressure, but also it's very important to reduce the risk of volutrauma. This is a very interesting animal study in which preterm rabbits were randomized to receive the same peak pressure, but in two different situations. In one situation, the preterm rabbit was maintained with the chest that was closed. The chest wall was not allowed to guarantee a variation of volume after the application of pressure. The other group of preterm rabbit was left to have the chest wall that was free to have a movement after the application of pressure. Only in this category of preterm rabbit in which the chest wall was left to have a movement, and so to generate a volume that in this category of animals, the lung injury was higher than in this one. So this was a very important experiment that demonstrated the volutrauma is very, very important. If you use a volume targeted ventilation like the volume guarantee, in which the ventilator adjusting continuously the peak inflation pressure in order to maintain the desired volume, after the surfactant replacement therapy, in which there is a sudden improvement of the compliance, the ventilator adjusts the peak inflation pressure in order to maintain constant the tidal volume. So when you use a volume guarantee ventilation, you can reduce the risk of overinflation, the volutrauma. In the literature, there are many papers that demonstrated that the volume guarantee is able to reduce the variability of the tidal volume and to reduce the risk of very low value of PCO2, so to reduce the risk of hypocarbia. And you know that hypocarbia is correlated to occurrence of leukomalacia, periventricular leukomalacia. In my unit, some years ago, we published this paper in which we compare pressure support ventilation versus pressure support ventilation plus volume guarantee with a tidal volume set at 5 in preterm infants with ARDS. We collected the tracheoaspirated fluids by bronchial lavage, and we measured the concentration of the cytokines. And we demonstrated that in baby ventilator without a volume guarantee, we show a very statistical increase of the cytokines in the tracheoaspirated fluids. Then we wanted to understand which could be the better tidal volume to use during the acute phase of RDS. So we compared 3 versus 5, and always we measure the concentration of the cytokines in the tracheoaspirated fluids. And we observed that in baby ventilated with the tidal volume set at 3, we observe a significant increase of the cytokine in the tracheoaspirated fluids. So we understood that in the acute phase of RDS, a low tidal volume is unable to open up the atelectasis lungs. In 2017 was published this Cochrane review that compared pressure limited ventilation versus volume targeted ventilation. They arrived at the conclusion that the targeted volume ventilation is able to reduce the occurrence of BPD and death, pneumothorax, to reduce the length of mechanical ventilation, rates of hypocarbia, and severe brain damage. In order to optimize the volume targeted ventilation, in order to give much more chance to be lung protected, we had to try to work with a PEEP, because the PEEP can reduce the alveoli swinging. So we are trying to optimize the level of PEEP and to avoid too low PEEP and too much higher PEEP in order to reduce of atelectasia, the overinflation. In my unit, we try to mimic the same strategy used by Van Kamm with the high-frequency oscillatory ventilation, using a trial in which we try to research the optimal level of PEEP in mechanically ventilated baby during assisted control plus volume guarantee ventilation. So under monitoring of the saturation and the level of IO2 needs for this baby, we try to increase the level of PEEP about 0.2 centimeter watt every 5 minutes, monitoring the falling of IO2 and rising of saturation. When the FiO2 needs fell to 0.3, we understood that probably arrive at the end of the pressure volume curve. So we started to reduce the PEEP level, always about 0.2 centimeter watt every 5 minutes. And when we observed desaturation and the need to increase the FiO2, we re-incremented again the level of PEEP until the stable oxygenation was achieved. In my unit, we randomized in this pilot study a group of preterm infants in mechanical ventilation to be managed with a static PEEP or a dynamic PEEP. And we observed that in these preterm infants, we were able to reach a significantly improvement of oxygenation in baby managed with this titration of PEEP. And in this group, we observed a tendency towards a lesser length of oxygen dependency. So in summarize, how to try to give to conventional mechanical ventilation a lung protective strategies. It's important to synchronize. It's important to choose the more appropriate modality according to lung disease, to choose the appropriate inflation time and the respiratory rate, to optimize the PEEP level, to use a voluntary ventilation, to research appropriate timing of surfactant therapy, monitor what happens during mechanical ventilation to try to extubate the patient as soon as possible. What happens during the high-frequency oscillatory ventilation? We can use the same strategy. So we can use also during high-frequency oscillatory ventilation a control of the tidal volume. We can use the volume guarantee. The volume guarantee during high-frequency oscillatory ventilation is a continuous regulation of oscillatory amplitude to compensate for dynamic change in the respiratory system. This modality of mechanical ventilation seems to be more associated with the fewer periods of hyperventilation and faster weaning. In this paper published by Colin Marlin in 2018 in preterm infants in HFOV for RDS, they demonstrated that using a tidal volume about 1.5 to 2 was enough to maintain a normal DCO2, and rarely the baby needed to increase the tidal volume more than 2.5 in order to maintain stable the DCO2. In order to be lung protective during high frequency, we are trying to research to use a very high frequency with the same low tidal volume. In these experiments published by our colleagues in Spain, they try to increase the frequency of the oscillatory ventilation, maintaining always the same tidal volume and monitoring the DCO2. So they step by step try to increase the frequency, and maintaining the normal CO2, they were able to maintain the same tidal volume with the high frequency that are correlated to the less lung injury. In terms of oxygenation strategy, we can use the strategy that was suggested by Mayadima and the Van Kamm in Amsterdam. And in fact, the recent Cochrane meta-analysis demonstrated that the high-frequency oscillatory ventilation is really able to prevent the lung injury, so to reduce the chronic lung disease only when is performed using a lung volume recruitment strategy as suggested by Van Kamp. In order to summarize how the high frequency respiratory ventilation could be lung protective, when is chosen as a first intention, when it started as a lung volume recruitment strategies, when we can associate the HFOV with a volume targeted ventilation, and when we try to use the higher frequency that allows a stable DCO2, when we are able to research appropriate timing for surfactant therapy, we can use appropriate monitoring, and when we try to extubate as soon as possible the patients. What we need for the future? I think that for the future, we had to try to use a better monitoring of the lung volume. And recently, two techniques seems to be very promising in order to give a lung volume monitoring. The first one is the use of the forced oscillation technique. This is a bedside method that can help the physician to identify the most appropriate positive end respiratory pressure or the continued distending pressure during a frequency, and can reduce the risk of lung tissue overdistension. The other modality to monitor the lung volume is the EIT, the electric impedance tomography, that can give information about the lung volume recruitment with a step-by-step increase of the pressure and a step-by-step decrease of the pressure. The big problem is that actually we don't have a belt that is appropriate to fit for the very premature infants. We hope in the future to have a very fitted belt in order to manage also the very premature infants during mechanical ventilation. So I want to give you some quick reference about the strategies for the different neonatal lung disease. We have to remember the respiratory equation of motion, where the delta pressure is dependent from the resistance, the flow, the compliance, and the volume. It's very important to consider resistance and the lung compliance. In fact, we can differentiate the lung disease in two big groups. The first group is the lung disease characterized with the presence of a relatively homogeneous lung disease, in which the lung compliance is the problem. And these are the RDS, in which the lung is recruitable, or the lung hypoplasia, in which the lung is not recruitable, or the congenital diaphragmatic hernia, in which the lung is only partially recruitable. Or the other group is the relatively non-homogeneous lung disease, in which it is a prevalence of high resistance, like happens for the meconium aspiration syndrome, lobar pneumonia, BPD. We have always to consider the correlation with the hemodynamics, because many babies during mechanical ventilation, there is a presence also of persistent pulmonary hypertension, or a presence of low left or right cardiac output, and the mechanical ventilation can have a negative impact on the hemodynamics. The RDS is a lung disease typically related to the absence or reduction presence of surfactant. It is characterized by decreased compliance to reduce FRC. In the acute phase, for all the baby, mechanical ventilation is necessary to give surfactant as soon as possible, in particular when FiO2 is not too much higher. When you use a conventional mechanical ventilation, I suggest to use assisted controls plus volume guarantee, and the tidal volume could be set at the beginning around at 5 or 6 ml per kilogram body weight. I suggest to use the pressure support ventilation plus volume guarantee only when the compliance becomes normal, for example, after surfactant therapy. This is an initial rate you can set about 40 to 60 BPM. This is the initial inflation time between 0.25 to 0.4 seconds. But this is only the initial IT, because you have to adjusting continuously the value of the inflation time according to the time constant of the baby according to the flow curve on the ventilator display. An initial PPAP around 5 to 6 could be enough. Then the positive end expiratory pressure could be tailored according to the capacity to recruit the lung. If you use the high frequency oscillatory ventilation, could be important if you have this opportunity to use the volume guarantee, and the tidal volume could be set initially around 2 ml per kilogram body weight, so you can research the optimal continued distending pressure according to the lung hysteresis. Mechanical aspiration syndrome. Mechanical aspiration syndrome is characterized by the marked resistance and sometimes could be associated with surfactant catabolism, and so the RDS and the persistent pulmonary hypertension. If the baby is mechanically ventilated, you can start with the synchronized mechanical ventilation. I suggest to use the SIMV, since the SIPPV can induce inadvertent PEEP and hyperinflation. So it's important to try to optimize the inflation time, the respiratory rate, and the PEEP level in order to try to reduce the risk of ventilator lung injury. In many cases for this baby, it's important to try to use the lowest tidal volume in order to maintain the normal gas exchange. In many cases, you can use the high frequency oscillatory ventilation. In some cases, it's necessary to use the lung volume optimization strategies, but always to try to use the lowest tidal volume and a constant CDP, and to try to reduce the lung injury occurrence. Volume target, when available, could be suggested. About the mechanical aspiration syndrome, you can have a different pictures. For example, B and C are very different one from the other one. In the C panel, there is a very high risk of hyperinflation and gas trapping. This is a typical situation in which the lung has not to be recruited, so you have to reduce the PEEP, you have to reduce the respiratory time, and in some cases it can be important to use a frequency oscillatory ventilation with the lowest tidal volume. In this situation, in which there is a marked atelectasia, in this situation it could be important to increase the PEEP level, to increase the peak inflation pressure, to increase the respiratory time, and in some cases to give, for example, the exogenous surfactant. For the congenital pulmonary hypoplasia, you have to pay attention in order to reduce the risk of pneumothorax. So in these cases, since the HFLV could be lung protected, in some cases much more than the conventional mechanical ventilation, HFLV could be suggested. And in these patients, it's very important to try to tailor the continued distending pressure according to the blood gas analysis, the chest X-ray. In some cases, when there is a persistent pulmonary hypertension, is indicated to use the INO and consider ECMO before to have a very important worsening of the oxygenation situation of these patients. For the CDH, congenital diaphragmatic hernia, all the baby are intubated in the delivery room, and if you use a conventional mechanical ventilation, you have to pay attention of the peak inflation pressure in order to reduce the risk of pneumothorax. When the peak inflation is too much higher, it's suggested to switch the baby from the conventional mechanical ventilation to the high frequency. It's very important, the hemodynamic management of these patients. Often in the delivery room could be useful to use a physiological base curve clamp in order to maintain a normal preload, in order to maintain a normal cardiac output. I know has to be used only after diagnosis of persistent pulmonary hypertension. For the BPD, bronchopulmonary dysplasia, these patients are characterized by reduced compliance, to increased resistance and increased work of breathing, and very high ventilation perfusion mismatching. If you use a conventional mechanical ventilation, remember to reduce the rate, and if it's possible to use a pressure support ventilation or SIMV in order to reduce the risk of air trapping. Generally is indicated a longer inspiration time because there is a longer time constant of this lung. IPEEP are often required and high tidal volume is often required. And remember that you have to use a very gradual weaning. In situations in which there is a persistent hypercapnia or high lung stiffness, HFLV is suggested. Anyway, if possible, avoid mechanical ventilation and use a non-invasive respirator support since the delivery room, as suggested by the recent European Consensus Guideline for all the spontaneous breathing baby, you can use to stabilize just the delivery room the use of CPAP with a CPAP level at least of 6 centimeter water by mask or nasal pranks. It's very important to stabilize this baby with a CPAP, because if you can be able to use the CPAP from the delivery room, you can reduce the risk of mechanical ventilation, you can reduce the risk of occurrence of BPD and death. So in conclusion, always try to promote spontaneous breathing early, functional residual capacity seen in the delivery room. And before to intubate the baby, please consider different modality of non-invasive respiratory support and try to tailor your approach. It's very important nursing care during the non-invasive respiratory support. Anyway, when mechanical ventilation is needed, if you are using the conventional mechanical ventilation, volume targeted ventilation, it's better than the pressure limited ventilation. Try always to optimize the level of PEEP and optimize the inflation time and the respiratory rate. If you use the high frequency oscillatory ventilation, it's suggested to use high lung volume strategies and use volume guarantee if available. Always try to tailor mechanical ventilation according to the different lung disease. It's very important when the surfactant is necessary to choose the appropriate timing. Remember that early it's better than late to give surfactant. We need a more adequate monitoring for the future. I think that the forced oscillatory technique and the EIT could be very promising approach to monitor the baby mechanical ventilation. Always consider cardiovascular interference of mechanical ventilation and always try to reduce the length of mechanical ventilation and so try to extubate the baby as soon as possible. Thank you very much for your attention.
Thank you, Dr. Lista. So we have around 10 questions that came in the Q&A. So I'm going to start with some of these questions. Now, unfortunately, I think we probably will not have time to answer all 10 questions, but we will do our best. Okay. So one of the first questions that came in was, please, can you share an example of how you apply DCO2?
I use the DCO2 monitoring for all the baby in high frequency oscillatory ventilation. And generally I use a reference about 25 to 40 of DCO2 in order to understand that the CO2 washout is enough or not for me. And so I try to adjust the delta pressure during frequency in order to maintain this value of the CO2 washout, or I use to adjust the tidal volume during the volume guarantee ventilation course of HFLV. Maintaining a minimal DCO2 washout around 40 to 50 ml for this baby. In generally, the CO2 washout is normal, and we can maintain the normal gas exchange for this baby.
Perfect. Thank you, Dr. Lista. So the second one, and this question is a little bit long, and it's kind of in two parts. In the early part of your presentation, in the HFOV illustration that you showed, you have a CDP of, for example, 20 centimeter HO2O with an amplitude that wraps around the CDP. The addition of an amplitude 40, for example, to the CDP, does this expose the patient to potentially higher peak air rate pressures, or is the ventilator simply showing the setting and attenuation reduces the alveolar pressure despite seemingly high pressure when amplitude is added?
This is a very interesting question. Yes, we had to try to reduce the delta pressure around the minimal pressure because we were trying to reduce the risk of trauma. In this case, we had to try to understand if the baby, for example, need to be managed with surfactant that can reduce the resistance to increase the FRC and so to increase the lung compliance, so can reduce the oscillation delta pressure. Anyway, we have to remember that during the high frequency respiratory ventilation, there is a marked continuous damping of the delta pressure for the primary airway to the small airway, so this risk is reduced during high frequency respiratory ventilation. Anyway, we are trying to reduce this oscillation of delta pressure, and so we have to optimize the mean airway pressure in order to use the lung hysteresis curve. When we are able to recruit the lung, generally we can reduce the oscillation of the delta pressure.
Okay, great, thank you. Another question came in and asking, when would you use HFO as the first line treatment option instead of a rescue ventilatory management system?
In general, I use the HFOV as a first intention, or in very premature infants, for example, 23, 24 weeks of gestation age with a severe RDS, in particular, if they were not managed during pregnancy with the steroids. So I suggest that the RDS could be very, very severe. I use the HFOV as a first intention in all the situations which I suggest to have a lung hypoplasia, for example, for a prolonged rupture of the membranes. I generally use the HFOV as a first intention for the CDH infant in my unit, and in many cases of severe meconic aspiration syndrome.
Perfect, thank you. Another question came in asking, why do we square the tidal volume in HFOV? And can you walk us through the calculation of square tidal volume times frequency equals volume of CO2?
This is the ruling which works the tidal volume in high frequency. So when I use the volume guarantee, and so the tidal volume remains stable, I know that because the tidal volume in the mechanical ventilation is regulated by the square of the tidal volume, I can change the frequency, and so increasing the frequency, I can add another possibility to guarantee the washout of the CO2. So this is what happens normally during the high frequency respiratory ventilation.
Great, thank you, Dr. Lista again. All right, so non-invasive CO2 monitoring, transcutaneous or end-tidal, please?
We use the CO2 on the display or the monitor or the ventilator in order to understand what happens in terms of efficacy of the CO2 washout, and so if the tidal volume, the frequencies are appropriate or not. But if I want to calculate what really happens in terms of gas exchange, I have the monitor the transcutaneous PCO2, who have to collect the arterial or capillary blood in order to calculate the CO2 in the blood.
Okay. Previously, when you mentioned HFO as the first line treatment, the question here is, would you extubate straight into CPAP, HFNC from this mode, or would you recommend a CMV mode before extubating?
This is another very interesting question. And when the clinicians are very skilled in using the HFOV, they are able to reduce the continuous standing pressure just a little bit more than the CPAP level. They can extubate the baby directly in CPAP. For example, when the CDP is around 8 or 7, and the need of FiO2 is close to 0.3. In other case in which you suspect that the baby is unable to be managed or in a CPAP, you can switch from the HFOV before in SIMV before to try to extubate the baby and so to manage the baby with non-invasive respiratory support. I think it's depend for how much the team is skilled in using the HFOV, not only during the acute phase of the respiratory failure, but also during weaning.
Great, thank you. Another question we got, and I think this is a question maybe we get too often. What maximum PEEP level would you be comfortable to set?
This is a very good question. And in general, the PEEP level could be very higher when the lung is very stiff. For example, during the beginning of RDS. And so we can stay a high level also at 10 in the delivery room, for example. When you give surfactant, when you achieve a sort of FRC, you just recruit the lung, we know that a PEEP level more than 8 centimeter water can have a negative impact on the hemodynamic, in particular on the return of the blood from the body to the heart. So I think that the PEEP level, maximum PEEP level could be 8 during the RDS management of very preterm infants.
Great. We still have some time for some questions, and more questions keep coming in. So the question now is, why not use PSV and volume guarantee in all settings, as it will prevent volume trauma, and just change the inspiratory time based on lung compliance?
The pressure support plus volume guarantee is a very interesting approach, but not all the preterm infants are able to manage this modality mechanical ventilation because they need to be supported much more. And if only you are able to improve definitively the lung compliance, for example, after surfactant, you can decide to use pressure support ventilation plus volume guarantee without any problems. If the lungs still remain affected by RDS, generally the inspiratory time is very, very short, and the baby, in order to maintain a normal minute ventilation, increase the respiratory rate. So the problem is that very tiny baby with a gestational age around 24, 25, or less than 1 kilo, sometimes increase the work of breathing, increase the respiratory rate in order to maintain the normal tidal volume. If you want to use a pressure support ventilation plus volume guarantee, you have to be sure to have given surfactant in order to increase the lung compliance, and to have to adjust very, very well the PEEP level, and to adjusting continuously the tidal volume in order to reduce the risk of work of breathing of these patients.
All right, thank you. Let's see. Do you prefer surfactant administration in HFOV mode?
No, I use a surfactant administration in all the modality of mechanical ventilation, both in conventional mechanical ventilation or in a frequency, or if the baby is non-invasive respiratory support, also during this modality of respiratory support. I think that surfactant administration is not related to a specific modality of mechanical ventilation. I think that could be given with all the modality of mechanical ventilation.
Awesome, thank you. Another question came in asking, do you use bronchodilator or budesonide for mechanical ventilation of the neonate?
In the routine assistance of very preterm infants, I don't use bronchodilator or budesonide. But sometimes in the chronically ventilated patients that are affected by BPD, sometimes I use the bronchodilator and the budesonide. This was suggested by our pneumologist.
All right. We have a question about targeted tidal volume setting for severe RDX and meconium aspiration syndrome. Can you describe like an ideal targeted volume?
I think that Martin Keslan right when he said that for the tiny baby, a baby below 1 kilo, you had to adjust the tidal volume in order to reduce the dead space related to the tracheal tube. So you have to reduce the length of tracheal tube, and so you can generally add 1 milliliter in order to reduce the dead space of the tracheal tube. I think that for the acute phase of RDS, for the very preterm infants, tidal volume around 5 to 6 could be enough. And if the mechanical ventilation is very, very short, you can reduce the tidal volume as soon as possible. On the contrary, if the baby is in prolonged mechanical ventilation is BPD infants, because there is an enlargement of the trachea and there is an increase of the dead space related to the mismatching in the lung, you have to increase the tidal volume, like was demonstrated by Anna Greenhoff. For the meconium aspiration syndrome, we try to use a low tidal volume when there is a risk of lung overinflation. So a tidal volume about 3.5 or 4 could be enough. In case of RDS, with severe attenuation, which you have to use a surfactant because there is an ARDS related to the meconium aspiration syndrome, you can increase the tidal volume more than 5, about 6, sometimes 7 is necessary.
Okay, next question. Do you worry about setting a very high peak inspiratory pressure, more than 30, for example, if the baby is volume guaranteed mechanical ventilation mode?
This is a good question. Sometimes there is a high PEEP during volume guarantee. If this happens in very tiny baby, in the acute phase of RDS, I think it's better or to switch the baby from the volume guarantee in commercial mechanical ventilation versus H frequency, it's better. Or to understand if you need to give surfactant, for example, or you can adjust the level of PEEP in order to reduce the need of high peak inflation pressure. Anyway, remember that the volutrauma it's much more important than the barotrauma. But when you can reduce the risk of peak inflation pressure. If this PEEP peak inflation pressure above 30 is in a BPD infants, don't worry because there is not so high risk. But anyway, always you have to try to reduce the level of peak inflation pressure.
All right, great. So there is another question that came in on meconium aspiration syndrome. Why use only SIMV and not SIMV plus PS?
This is a good question. I think that at the beginning you can use only SIMV in order to reduce the risk of trapping. But if you observe that the baby show an increased work of breathing, it's better to associate the pressure support to the SIMV. Is a good option.
Okay, and I think one last question because we are at the top of the hour. So what should be the maximum inspiratory pressure during guaranteed volume ventilation? During CMV plus volume guarantee, to change the volume, we must consider CO2 or pH.
I think that there is not a specific maximum inspiratory pressure to use during volume guarantee. I think that depends from a specific baby. When the peak inflation pressure is too much higher, I think that will resolve the problem. Or to give surfactant to switch the baby from the HFOV.
Perfect. Thank you, Dr. Lista. So it's the top of the hour. We still have some questions that we weren't able to answer. However, what I can do is I can send the questions to Dr. Lista in a separate email, and maybe he can provide us with some answers that I can provide you a
Absolutely.
little bit afterwards, because some of the questions need a little bit more details about FOT, etc. So it's big questions that we don't have time to answer. But I guess thank you everyone for attending today. Thank you very much, Dr. Lista, for this great lecture.
You're welcome.
A replay will be available and will be put online, so you can obviously watch this webinar again and again and again and again. Absolutely no problem. Thank you very much and enjoy your day, afternoon, everyone.
Okay, bye-bye.
Thank you.